Morning, teachers and my dear friends. So today's topic for practice parameters will be trigeminal neuralgia and its mimics. So trigeminal neuralgia is a pain attributed to a lesion or disease of the trigeminal nerve. It has also been called tic doloro and a disorder. So this is a disorder characterized by recurrent, unilateral, brief electric shock-like pain, abrupt in onset and termination, limited to the distribution of one or more distribution of the trigeminal nerve and triggered by innocuous stimuli. So the lifetime prevalence is estimated to be 0.16 to 0.3% with an annual incidence of 4 to 29 per 1 lakh person years. And it is slightly more common in women, and the average age of onset is in the 6th decade. And it is rare in young children and young adults and children. So this is the current classification of trigeminal neuralgia. So it can be classified into idiopathic, classical, as well as secondary. So in idiopathic trigeminal neuralgia, that all the diagnostic tests will be negative, and there will not be any lesion or disease known to cause trigeminal neuralgia. And in the classical form, there will be demonstration of a neurovascular compression, either demonstrated by on an MRI or during surgery. And in the secondary trigeminal neuralgia, an underlying disease has been demonstrated, and this is known to be able to cause and explaining the neuralgia. So both the idiopathic as well as classical can be divided further into purely paroxysmal pain and with concomitant continuous pain. So now coming to the international classification of headache disorder, 3 diagnostic criteria for trigeminal neuralgia. So first, recurrent paroxysms of unilateral facial pain in the distribution of one or more divisions of trigeminal nerve with no radiation beyond and fulfilling criteria B and C should be there. So criteria B is pain has all the following characteristics. So that is, one is lasting from a fraction of a second to 2 minutes, severe intensity, electric shock like shooting, stabbing, and sharp in quality. So this should be precipitated by innocuous stimuli within the affected trigeminal distribution. So now coming to the cardinal features of trigeminal neuralgia pain. So first is laterality as well as the site of pain. So one is the right-sided predominance is most commonly seen in trigeminal neuralgia pain. So that is right side is affected in almost 60% of trigeminal neuralgia cases. Bilateral presentations, that is simultaneous bilateral pain, is rare, and it is more common manifestation is the side alternating unilateral paroxysms. So next is what are all the red flags? Bilateral side alternating pain, we should be highly suspicious for other neurological disorders like multiple sclerosis, tumors, as well as vascular malformations, and other non-neurological conditions like systemic diseases, connective tissue disorders, as well as cranial pathologies should be considered. So the pain of trigeminal neuralgia is most frequently affects the V2 as well as the V3 distribution than the V1 distribution. So coming to the frequency and duration of attacks. So more attacks last less than a second up to 2 minutes, and a minority experience attacks lasting for 2 to 10 minutes. But up to 70% may have series of paroxysms lasting up to 1 hour. And so frequency ranges from a few to several hundred attacks per day, and about 40% of patients report more than 10 attacks daily. So triggerability is a hallmark feature, and 91 to 99% of patients report attacks triggered by innocuous mechanical stimulation of the face or the intraoral mucosa on the same side of the face. And absence of triggerable attacks should prompt careful assessment for alternative diagnosis. So the common triggers include the light tactile stimulation, painful or thermal stimulation, light tactile stimulation, which is most potent, that is touching the face, brushing, chewing, speaking, washing, drying, as well as drinking, as well as shaving. But painful as well as thermal stimulation is usually ineffective, and there will be trigger sounds, usually the nasolabial fold, upper lip, the lateral lower lip, chin, cheek, alveolar gingiva, as well as gums. And refractory period is a distinguishing feature of trigeminal neuralgia from other facial pain disorders. So this happens due to hyperpolarization of the sensory neuron after an attack, reducing its excitability temporarily. Now coming to the differential diagnosis or the trigeminal neuralgia mimics. So these include dental causes like dental caries, pulpitis, dental sensitivity, periodontal disorder, pericoronitis, cracked tooth, as well as alveolar osteitis. So neuropathic pain include glossopharyngeal pain, nervous intermediate pain, post-herpetic neuralgia, post-traumatic trigeminal neuropathy. And other trigeminal autonomic cephalalgias like Sunk Suna, paroxysmal hemicrania, cluster headache, hemicrania continua. So other causes include persistent idiopathic facial pain, primary stabbing headache. So maxillary sinusitis, salivary stones, temporomandibular joint disorders also cause facial pain. So now, what are the cardinal differences between the trigeminal neuralgia pain as well as Sunk and Suna? So trigeminal neuralgia usually affects the V2, V3 distribution, whereas trigeminal autonomic cephalalgias usually affects more of V1 distribution. And next classical difference will be the duration of symptom. Usually trigeminal neuralgia will be less than 1 to 120 seconds, whereas trigeminal attacks will be of more duration. And autonomic features will be prominent in trigeminal autonomic cephalalgias, as well as refractory period will be absent. And periodicity, that will be more chronic. And usually lamotrigine is more effective in trigeminal autonomic cephalalgias than the trigeminal neuralgia. So we'll discuss in detail the medical management of trigeminal neuralgia. So the first line management is carbamazepine as well as oxcarbamazepine. Now coming to the differentiating features between trigeminal neuralgia, cluster headache as well as hemicrania continua. So in hemicrania continua, the pain will be more of a throbbing and more severe burning as well as throbbing. And in hemicrania continua, it will be constant, continuous unilateral pain, usually periorbital as well as temporal region. Whereas in the cluster headache, the pain will be of 15 to 180 minutes per attack, will be unilateral, and usually that will also be periorbital as well as temporal. And so triggers usually will be non-specific or often not present in hemicrania continua, but whereas alcohol may trigger cluster headache. And autonomic symptoms are common in both cluster headache as well as hemicrania continua, but that is rare in trigeminal neuralgia. And next is the attack pattern. So we know that trigeminal neuralgia pain will be brief paroxysmal multiple daily attacks. In cluster attacks, cluster headache, the attacks will be in clusters. That is usually weeks, and then patient will go into remission. And in hemicrania continua, it will be usually continuous with no pain-free period. And trigeminal neuralgia is more common in women, but whereas cluster headache is more common in men. And in hemicrania continua, no gender predilection is there. And indomethacin, usually trigeminal neuralgia as well as cluster headache will not respond to trigeminal neuralgia, whereas hemicrania continua will have a diagnostic response. So now other differential diagnoses include the dental pain, so which is continuous intraoral pain that is dull or throbbing, whereas trigeminal neuralgia pain is typically intermittent as well as sharp pain. Glossopharyngeal neuralgia is characterized by paroxysms, that is sudden attacks of severe, brief, unilateral pain, and the pain is triggered by action like chewing, swallowing, coughing, as well as talking, yawning, sneezing, or touching the posterior pharynx. So trigger site is the posterior pharynx, that is back of the throat, unlike trigeminal neuralgia, where oral as well as the facial structures are involved. So next is nervous intermediate neuralgia. So nervous intermediate is a branch of facial nerve, and it produces triggered neuralgic pain in the auditory canal. So the pain may radiate to trigeminal regions of the face in some patients, but prominent inner ear pain, usually identifies the nervous intermediate neuralgia. So now coming to the primary stabbing headache, it is characterized by transient, sharp stabbing pains that typically occurs in the frontal or the parietal cranial locations, including within the trigeminal dermatomes in some patients. And most of the stabs of pain last only for few seconds. And the symptoms are spontaneous rather than triggered. And in primary spontaneous primary stabbing headache, and extra trigeminal location of some or all attacks can also help differentiate the trigeminal neuralgia pain. So next, another entity is the first bite syndrome. So these are the paroxysmal facial pain or cramping induced by the first bite of a meal with subsequent lessening or on further bites. So pain can also be precipitated by swelling food. So it can be distinguished from trigeminal neuralgia due to its association with deep parotid lesions and prior surgery that included neck dissection or lack of cutaneous triggers. Now coming to secondary trigeminal neuralgia. So it refers to the trigeminal neuralgia that arises due to identifiable underlying medical condition or structural lesion. So the major causes include, so the parts of the trigeminal nerve can be divided into the brainstem segment, the cisternal segment, the trigeminal ganglion that is in the Meckel's cave, then in the cavernous segment as well as the peripheral segment. So the DDs as well as the causes will also change accordingly. So in the brainstem segment, demyelination, that is multiple sclerosis, neoplasms, vascular causes like cavernoma, infarction, AV malformation, rhomencephalitis are the most common causes. Cisternal segment, neurovascular compression is the most common cause for trigeminal neuralgia. Other neoplasms like schwannoma, meningioma, epidermoid, as well as perineural spread are also common. And infection and inflammation, meningitis, as well as Petrus-Born epicytis is also common in the cisternal segment. In the Meckel's cave segment, as well as the cavernous segment, both the neoplasms like schwannoma, meningioma, epidermoid, perineural spread, as well as the skull-based lesions are common. And in the cavernous sinus, in addition, there will be the vascular aneurysm because of arising from the ICA, as well as infection or inflammation like Tolosa-Hunt syndrome can also affect. And in the peripheral segment, again, neoplasms because of the perineural spread, schwannoma as well as neurofibroma can happen. And so many sinonasal infection or as well as inflammation can also affect. So now coming to neurovascular compression. So what is neurovascular compression? So it is defined by specific radiologic criteria. So one is the blood vessel concerned is almost always an artery. The nerve and the blood vessel run perpendicular to each other, and there is a mass effect of the vessel on the nerve, and the contact between the blood vessel as well as the nerve occur in the root entry zone of the nerve. So now we will see an example. So this is a 3D Fiesta sequence, and this shows that there is compression, that is vascular compression in the root entry zone of the right trigeminal nerve. So here we can see that one artery is there. So that is the right superior cerebellar artery. So that artery is in close relation with the right trigeminal nerve. And it is located in the root entry zone. And the nerve as well as the vessel course perpendicular to each other. And the nerve is displaced laterally. So this is a case of neurovascular compression. So this is another image showing axial T2 image of the lesion. So here we can see there are two lesions. So one in the Meckel's cave and another in the cisternal segment of the trigeminal nerve. So after giving gadolinium contrast, the Meckel's cave lesion is enhancing homogeneously, and the cerebella, that is the cerebellopontine cistern lesion, is completely cystic. So this is a case of trigeminal schwannoma, and this appearance is called the dumbbell-shaped appearance. So now the main features, that is distinguishing features between the primary as well as secondary trigeminal neuralgia include. So one is the quality of pain. In the primary trigeminal neuralgia, the pain will be mostly acute, stabbing, electric shock-like, And in the secondary trigeminal neuralgia, it will be more constant, as well as burning type. And figures are usually less usually present in primary trigeminal neuralgia, and it is less clearly defined in secondary trigeminal neuralgia. So an underlying cause like neurovascular compression, or it can be idiopathic in primary trigeminal neuralgia. And in the secondary trigeminal neuralgia, usually tumors, multiple sclerosis, cyst injury will be there. And pain-free periods are less common in secondary trigeminal neuralgia. And secondary, usually it can be unilateral or even bilateral, but primary, it will be mainly unilateral. So our question will be, for patients with trigeminal neuralgia, which kind of imaging should be done to demonstrate the neurovascular compression and rule out other causes of trigeminal neuralgia? So here, so this is a study that analyzed the severity of the neurovascular contact in patients with trigeminal neuralgia with 3D MR cystonogram as well as angiogram fusion imaging. So here the frequency as well as severity of the neurovascular compression among the affected contralateral as well as normal trigeminal nerves were analyzed using 3D MR cystonogram as well as angiogram fusion. And the inner view of the fusion MR imaging projected from inside the trigeminal nerve was used. And the severity of the neurovascular compression was classified into none, simple, moderate, as well as severe, according to the nerve circumference in contact with the vessel. So they found that the neurovascular, so here total of 66 patients with affected nerves and 66 with that is neurovascular compression of the contralateral nerve, and 39 controls were taken. And they found that the neurovascular compromise in the affected trigeminal nerve was observed more frequently and much more severely than that at the contralateral as well as normal trigeminal nerve in the controls with a positive p-value. So another study that studied the visualization of the vascular compression with resolution of the 3T MRI, which was a prospective study that included 40 consecutive patients, and all, so this is in the pre-operative analysis. And they have done 3T MRI with 3D T2 weighted driven equilibrium, that is the drive sequence, 3D TOF, as well as 3D TOF MR angiogram, as well as 3D T1 weighted gadolinium enhanced sequences. So they found that that is 3T MRI using 3D T2 weighted drive in combination with 3D TOF MRI and 3D T1 weighted gadolinium enhanced sequences proved to be reliable in detecting neurovascular compression and in predicting the degree of root compression, and the outcome being correlated with the latter. So now, based on these studies, so European Academy of Neurology 2019 guidelines recommend that MRI should be performed in all patients to exclude secondary causes of trigeminal neuralgia, and a combination of 3 high-resolution sequences, that is 3D T2 weighted, 3D TOF MRI, as well as 3D T1 gadolinium enhanced, helps in the detection of possible neurovascular compression. And this is another guideline which is published in 2003 by the Cleveland group. And they also suggest that thin slice MRI of the brain as well as the internal auditory meatus is suggested in all the patients with trigeminal neuralgia. So now, 3D sequences, TOF. Now, coming to the treatment of trigeminal neuralgia. So these include the preventive pharmacotherapy, adjunctive rescue therapy, as well as surgical management. So now coming to preventive pharmacotherapy. So daily treatment is cornerstone for idiopathic or classical trigeminal neuralgia. And the pain associated with secondary trigeminal neuralgia can be treated with same medications. So initial preventive medications, the first line available options include carbamazepine as well as oxcarbamazepine. So carbamazepine, the starting dose is 100 to 200 mg twice daily, and increased by 200 mg every 1 to 2 weeks as tolerated. And the maintenance dose of 600 to 800 mg daily, that is split into 2 doses for tablets as well as capsules, and 4 doses for oral suspension and chewable. And a maximum dose of 1200 mg daily can be given. So adverse effects include nausea, vomiting, diarrhea, hyponatremia, rash, pruritus, drowsiness, dizziness, blurred vision, as well as lethargy and headache. So slow titration may reduce the side effects. So HLA-B1502 allele can be tested as it is a genetic marker for increased risk of Stevens-Johnson syndrome, as well as toxic epidermal necrolysis. So this is a trial that got published in JAMA Neurology, and it was a double-blinded placebo-controlled trial, which included 30 patients with trigeminal neuralgia. So it was a double-blind crossover trial, and the patients received both carbamazepine and placebo in random order. And the dosage which they have used is 400 to 600 mg per day initially, which titrated up to 1000 mg per day as needed. So duration, the treatment periods ranged from 2 weeks to 36 months. And the outcomes include pain relief, that is either reduction or the disappearance of the pain, side effects, as well as laboratory monitoring. So the results include 24 out of 30 showed initial pain relief within 24 to 72 hours of starting carbamazepine, and 19 out of 27, that is 70%, had complete or very good recovery, including 3 complete remissions, 4 partial remissions. And 8 out of 27, that is 30%, could not be maintained on carbamazepine alone. And some may require additional therapy as well as surgery. So this is another 4-year double-blind study of Tegretol, and they evaluated the long-term efficacy as well as safety in treating facial pain and particularly trigeminal neuralgia. So study duration was 46 months, that is nearly 4 years. And carbamazepine was compared to placebo in a double-blind randomized design. And the long-term follow-up showed patients received either carbamazepine or placebo in a randomized double-blind fashion. So efficacy was assessed by pain relief, safety was monitored via side effects reporting as well as laboratory studies. So this study found that carbamazepine provided significant as well as sustained pain relief in most patients with trigeminal neuralgia. So this was the result, that is the table showing the results. So in the carbamazepine only group, that is which included 20 patients, so excellent outcome was seen in 7, and good outcome was seen in 8, as well as poor outcome was seen in 1, and 4 had unchanged clinical symptoms. So now coming to oxcarbazepine. So generally they are better tolerated than carbamazepine, so with fewer as well as less severe side effects. So that causes fewer side effects and have lower potential for drug interaction than carbamazepine. So excessive central nervous system depression as well as dose-related hyponatremia can occur, and women are significantly less tolerant to oxcarbazepine. So 200 mg of carbamazepine, oxcarbazepine. So 200 mg of carbamazepine is equivalent to 300 mg of oxcarbazepine. And the contraindications for both these drugs are cardiac conduction problems as well as allergic reactions, severe allergic reactions like Stevens-Johnson syndrome. So this study by Stefano et al. So they studied the natural history as well as outcome of 200 outpatients with classical trigeminal neuralgia treated with carbamazepine or oxcarbazepine in a tertiary center for neuropathic pain. So initial 100 consecutive patients with typical trigeminal neuralgia who began treatment with carbamazepine, and the next 100 with oxcarbazepine. And the initial number of responders was 98% with carbamazepine, with a median median dose of 600 mg, whereas 94% with oxcarbazepine was maintained at a median dose of 1200 mg. And the mean period of 8.6 months in 27% of responders to carbamazepine developed undesired side effects, whereas the mean period of 13 months, 13 months in 18% of oxcarbazepine responders developed side effects. So they concluded that unlike common notion, both carbamazepine as well as oxcarbazepine were confirmed efficacious, but the side effect when compared to carbamazepine, oxcarbazepine has lesser side effects. So other preventive pharmacotherapy include second-line agents, like first is gabapentin. So that should be started at 100 to 300 mg once daily and increased by 300 mg every third day as needed and tolerated up to a typical therapeutic dose of 900 mg per day and a maximum dose of 2400 mg per day can be given in 3 divided doses. So gabapentin, usually it's a well tolerated drug, but when titrated slowly, may cause sedation, dizziness, as well as weight gain. So this is meta-analysis which compared the efficacy of and safety of gabapentin versus carbamazepine. So this meta-analysis showed total effective rate of gabapentin therapy group was similar with the carbamazepine therapy group. And while the effective rate of gabapentin therapy for 4 weeks was higher than that of carbamazepine, and the life satisfaction as well as the life satisfaction in 4 weeks, as well as the adverse reaction rate was less. I mean, life satisfaction improvement was more, as well as the adverse reaction rate was less in the gabapentin therapy group with a significant p-value. So this study showed that gabapentin was shown to be possibly effective and to have fewer side effects when compared to carbamazepine. So next drug is lamotrigine. So start lamotrigine at 25 mg once daily, if not on other anti-seizure medication. And it can be increased 50 mg every 1 to 2 weeks up to 400 mg daily as needed. And if the patient is taking enzyme-inducing, other enzyme-inducing anti-seizure medications like carbamazepine, phenytoin, as well as primidone, start at 50 mg daily and increase slowly to 100 mg at week 3, then 200 mg at week 5, and 300 mg at week 6, and 400 mg in week 7. So if if the patient is taking enzyme inhibiting drug like valproate, start at 12.5 to 25 mg every other day and increase by 25 mg every 2 weeks up to 200 mg daily. So it is dosed once daily as an extended release formulation. So rash as well as nausea are common side effects. Serious rash may occur if dose escalation is too rapid. So this study which got published in the Journal of Headache as well as Pain studied the lamotrigine in refractory trigeminal neuralgia, and that was a double-blind placebo controlled crossover trial. And the patient continued to take steady dose of carbamazepine or phenytoin throughout the trial over a 31-day period. And each arm of the trial lasted 2 weeks with an intervening 3-day washout period. And they also found that lamotrigine can be, that is, the global evaluations further suggested that patients did better on lamotrigine than the placebo with a significant p-value. So next drug tried was baclofen. So it typically started at 5 to 10 mg once daily and increased by 10 mg up to every 3 days to a typical daily maximum dose of 80 mg. So it can be given as 3 to 4 divided doses. Drowsiness, nausea, as well as dyspepsia are common adverse effects. And the drug should be discontinued slowly since seizures as well as hallucinations have been reported upon withdrawal. Another drug tried is pregabalin. So the gabapentinoids, similar to pregabalin, that may be used for the patients with trigeminal neuralgia. So can be started at 25 mg daily and can be titrated to a usual therapeutic daily dose of 150 to 600 mg, given in 2 to 3 divided dose. So this is another prospective open-labeled study that evaluated the efficacy of pregabalin treatment in patients with trigeminal neuralgia. And they have studied 53 patients with trigeminal neuralgia. And 53 patients with trigeminal neuralgia received pregabalin, 150 to 600 mg, and were prospectively followed for 1 year. And the primary outcome was the number of patients pain-free or with reduction of pain by more than 50%. And the secondary outcome was sustained pain relief after 1 year. So they found that the pregabalin without concomitant facial pain showed better response rate compared to patients with concomitant chronic facial pain with a significant p-value. So now coming to the role of botulinum toxin injection in trigeminal neuralgia. So this botulinum toxin A or onabotulinum toxin. So it is a type of exotoxin produced by Clostridium botulinum. So it acts. The main role of botulinum, that is a mechanism of action in trigeminal neuralgia, is the inhibition of release of various neurotransmitters, including substance P, CGRP, dopamine, norepinephrine, as well as enkephalin and neurokinin. So botulinum toxin A reduces the afferent nerve impulses and suppress the neurogenic inflammation and prevents the peripheral sensitization. So usual doses 50 to 100 units injected subcutaneously or intramuscularly at multiple sites along the affected branches of the trigeminal nerve. Another protocol involved is 50 units injected subcutaneously at sites 1 centimeter apart and 10 units intramuscularly into the masseter for involvement of the third branch. So the periodicity of as well as repetition. So the maximum efficacy of botulinum toxin A is observed between 6 weeks to 3 months after injection, and the duration of the pain relief varies among patients, but the recurrence of pain typically occurs after an average of 2 to 3 months. So injections can be repeated when pain recurs, and generally every 3 to 6 months, depending on the patient's response as well as recurrence of symptoms. So this article, which got published in the Journal of Headache as well as Pain, studied the therapeutic effects of botulinum toxin A in 88 patients with trigeminal neuralgia with a 14-month follow-up. So a visual analog scale, the pain attack frequency per day, patient's overall response to treatment, as well as side effects during 14 months follow-up was evaluated. And they divided the patients into less than 50, 50 to 100, as well as more than 100 units. And the therapeutic effect was evaluated. So they found that the treatment was deemed effective within 1 month in 81 patients and at 2 months in 88 patients, that is 100%. And the shortest period of effective treatment was 3 months. And complete control of pain was observed in maximum of 46 patients. And the therapeutic effect decreased gradually after 3 months. And the prevalence of effective treatment at 14 months was 38.6%, with complete control of pain seen in 25% of patients. So local subcutaneous, so they concluded that local subcutaneous injection of botulinum toxin A for treatment, that is trigeminal neuralgia treatment, has considerable therapeutic effect lasting several months, and it is safe for this indication. So this is another study that studied the therapeutic efficacy as well as safety. And this is a meta-analysis of total 4 RCTs with a total of 178 patients. And the overall effect favored botulinum toxin A versus placebo. And the paroxysm frequencies per day was significantly lower for botulinum toxin A group. So this is an overall summary of the drugs that can be used in trigeminal neuralgia. So carbamazepine, we know that it should be initiated at 200 mg and 200 mg every 3 days should be titrated. And the dose range between 200 to 1200 can be divided into 2 to 4 times per day. And while tapering also 200 mg every 7 days we have to taper and stop. So oxcarbamazepine, carbazepine, the initiating dose is 300 mg, and that should be increased every 3 days to a maximum dose up to 1800 mg. Can be divided in 4 times per day. And the tapering also should be done 300 mg every 7 days. So next is lamotrigine, that is the initiating dose is 25 mg and for 2 weeks, then slowly titrate 50 mg for 1 week, then increase by 50 mg every week. And the maximum dose should be 400 mg, can be given as twice per day. And while tapering also reduce by 50 mg every 7 days. Gabapentin can be given 300 mg, that is as a starting dose, and titrate every 3 days. And the dose range, it can go up to 3600 mg in 3 divided doses. And while tapering, 300 mg should be tapered every 7 days. And pregabalin start as 150 mg and slowly titrate every 7 days up to 600 mg. The frequency is 2 times per day. And while tapering, can taper 100 mg every 7 days. Baclofen can be started at 15 mg and can be titrated every 7 days. And the dose can go up to 90 mg 3 times per day. And botulinum toxin type A, they have given the dose of up to 25 to 195 units every 12 weeks. But so many recommendations as well as studies are showing 3 months is the average duration. So now coming to the acute, ma'am, all these are add-on therapies. Are the first line. Yes, ma'am. This botulinum toxin already they have tried on patients taking carbamazepine. And sometimes they will stop because of the serious side effects. But they found that this botulinum toxin is effective as monotherapy also. So now it's coming. Usually 2 years is the average duration. Cannot taper. So now coming to acute rescue therapy for patients with breakthrough pain. So rescue therapy may be used during the initial titration of preventive pharmacotherapy. So the options include intranasal or intravenous infusions of lidocaine, subcutaneous injections of sumatriptan, intravenous phenytoin as well as fosphenytoin as well as intravenous lacosamide. So here in the study on lidocaine, aerosol sprayed on oral as well as on nasal mucosa, which was a retrospective study. They found that lidocaine administered intranasally or intraorally as 2.4% aerosol, that is 32 mg per dose, was reported effective in a retrospective study of 152 patients in China with severe pain from trigeminal neuralgia. And this is another study that studied the benefit of subcutaneous sumatriptan. And the benefit of sumatriptan at 3 mg given by subcutaneous injection was shown in a small placebo-controlled crossover trial. So with improvement persisting for a mean duration of approximately 8 hours. So another other drugs that can be tried are phenytoin. So with a dose of 250 to 1000 mg given intravenously at no more than 50 mg per minute. An alternative weight-based single dosing is 15 mg per kg given over 30 to 120 minutes. So lacosamide can also be given as acute rescue therapy. The infusion dose is 50 to 400 mg and the adverse effects were mild. So the European Academy of Neurology 2019 guidelines recommends that very low quality of evidence, given the very low quality of evidence, there is weak recommendation for the use of intravenous phenytoin, that is fosphenytoin, as well as lidocaine in acute exacerbation. And the Cleveland group, they give the treatment as lidocaine can be used either as 10 mg nasal spray, 2 sprays into nostrils on affected side, and it can be used intraorally but split out after 1 minute. And 5% ointment can be applied to the triggered area, and 2%, that is 1:80,000 adrenaline local infiltration to the nerve block trigger area can also be used. And another is sumatriptan 6 mg subcutaneous injection followed by oral sumatriptan 50 mg twice daily for 1 week is another option. Botulinum toxin A injection 3 mg in 1 ml can also be, so they recommend its use also for the abortion of acute attacks. And so next is intravenous infusions like lidocaine 1.5 mg per kg over 1 hour up to 5 mg per kg in a randomized control trial, and phenytoin 10 mg per kg as well as fosphenytoin 15 mg per kg can be used. So now the current as well as emerging pharmacotherapies for trigeminal neuralgia include carbazepine, and it's a active metabolite of oxcarbazepine, and it can be started as initial dose of 400 mg oral once daily, and the dose can be increased by 400 to 600 mg per week to a maintenance dose of 800 to 1600 mg once daily. So maximum recommended dose is 1600 mg once daily. So this study was the first human study to evaluate eslicarbazepine for trigeminal neuralgia with a mean follow-up of 21 months. So they showed that eslicarbazepine was effective. Pain intensity score decreased significantly from 9.5 to 2.5 over the course of treatment, and mean episodes per week decreased to 70 from 70 to 0.37. So now coming to the CGRP antagonist. So CGRP is a 37 amino acid peptide and powerful vasodilator found both periphery as well as the central neurons. So examples include erinumab, fremanezumab, galcanezumab as well as eftinezumab. So this is a article, a study that studied the safety as well as efficacy of erinumab in patients with trigeminal neuralgia in Denmark, and this got published in Lancet Neurology in November 2022. So they included a total of 91 patients, 119 participants, and so 93 participants entered a 4-week baseline period with 13 excluded after randomization. So there was, and they found that there is no difference between the groups in the number of responders at 4 weeks in the intention to treat population of 40 with erinumab versus 80. So erinumab, they concluded that erinumab did not reduce the pain intensity compared with the placebo in patients with trigeminal neuralgia. So next drug is lasmiditan. So it is a highly selective 5-HT1F receptor antagonist. Its efficacy in treatment efficacy in acute migraine is well established, but its role in trigeminal neuralgia remains to be established. Only certain case reports are available. So next is pimoside. So it's a dopaminergic antagonist and antipsychotic used in Tourette syndrome and sometimes in trigeminal neuralgia. So the typical dosing starts at 2 to 4 mg per day, and it is titrated up to 12 mg per day based on the response as well as tolerability. So after initial pain control, so the dose can be gradually reduced to a minimal effective dose. So this article that got published in JAMA Neurology, it's a double-blind crossover study of 48 patients with refractory trigeminal neuralgia, and they found that pimoside 14 to 4 to 12 mg per day led to pain reduction in refractory cases when compared to 56% with carbamazepine at a dose of 800 to 1200 mg per day. So next drug is tisanidin. It's a short-acting muscle relaxant, and it's an alpha-adrenergic agonist with a central mechanism of action. So it is similar to clonidine and has analgesic as well as myorelaxant property. So its role in trigeminal neuralgia is not yet clear, but there is a double-blind trial studied tisanidine up to 18 mg per day was compared to carbamazepine up to 900 mg per day in 12 trigeminal neuralgia patients. They found that tisanidine was less effective for pain relief than carbamazepine, but it was well tolerated. So European Academy of Neurology guideline 2019 recommend there is strong recommendation for carbamazepine as well as oxcarbazepine, and there is weak recommendation that lamotrigine is used as monotherapy or as add-on therapy for long-term treatment of trigeminal neuralgia. And there is a weak recommendation for gabapentin that can be used as monotherapy or add-on therapy. They also recommend botulinum toxin, that is with a very low quality of evidence. And this Cleveland group also recommend the treatment with first-line oxcarbamazepine, carbamazepine as well as oxcarbazepine. And second-line agents that can be used are lamotrigine, baclofen, gabapentin as well as pregabalin. Now coming to the surgical treatments in trigeminal neuralgia. So this include invasive non-ablative procedure like microvascular decompression. Next is invasive ablative controlled lesioning of trigeminal ganglion or root by either mechanical, that is balloon compression, thermal, that is radio frequency thermocoagulation, or chemical, which is glycerol rhizolysis, as well as non-invasive ablative tactic radiosurgery can also be used. So coming to microvascular decompression, it's a major neurosurgical procedure. So it involves craniotomy as well as removal or separation of various vascular structures. And the microvascular decompression is most effective surgical technique for the classical trigeminal neuralgia. So here the first image shows the CIS-3D image showing the right trigeminal nerve getting compressed by the right superior cerebellar artery. And this is the intraoperative image showing in the red, that is image B. So this is the superior cerebellar artery that is compressing on the trigeminal nerve. And after the surgery, they have separated the artery from the trigeminal nerve. Gauze piece will be kept in between. Gauze, some I don't know what is some glue gel foam. Gel foam will be kept in between. So, so this study assessed the effectiveness of microvascular decompression, and 220 patients with microvascular decompression and 53 patients with partial sensory rhizotomy was studied, and the overall satisfaction was high for microvascular decompression. And they concluded that primary microvascular decompression yields higher satisfaction. And this is another study that is 148 patients, consecutive patients were studied. And this study included 10 patients with multiple sclerosis also. So they found that there is vascular compression in all the cases, and excellent results are seen with microvascular decompression in 5 out of 10 multiple sclerosis patients. So they also concluded that microvascular compression likely has a neuromodulatory role. So this study concluded that post-operative trigeminal numbness is linked to operative findings, not tick relief. So next procedure is rhizotomy, that uses percutaneous technique to lesion the trigeminal nerve via the foramen ovale under imaging guidance. So the lesion options include either heat or mechanical, or it can be chemicals like glycerol. And the main complications include aseptic meningitis, but some maxillary artery injury dural laceration as well as possible oculomotor nerve injury was also the risk factors. So in this study, so after 1 month of this percutaneous radiofrequency ablation, so they found that it is statistically as well as clinically significant greater pain relief was obtained in the patients with percutaneous radiofrequency ablation than the sham procedure after 1 month of follow-up. So now coming to the radiosurgery, that is stereotactic radiosurgery using gamma knife or X-rays to treat imaging defined targets. It creates the therapeutic lesion. And for trigeminal neuralgia, the target is the proximal trigeminal root, and targeting the Caesarean ganglion gives poor results. And a stereotactic frame and MRI guide beam is used, and the radiation doses range from 70 to 90 grays. And the beams cause axonal degeneration as well as necrosis. So this is the mechanism. And this study which included 220 patients with idiopathic trigeminal neuralgia, out of which 125 patients have previously undergone surgery, and 80 had some degree of sensory disturbance related to the earlier surgery. So the patients were followed up for a maximum of 6.5 years, and a complete or partial relief was achieved in 85% of patients after the stereotactic radiosurgery at 1 year, and a complete pain relief was observed in 64.9% at 6 months. So the absence of preoperative sensory disturbances as well as previous surgery correlated with an increased proportion of patients who experience complete or partial pain relief over time. So this is a comparison table between each surgical option. And here we can see that pain-free at 5-year follow-up was maximum for microvascular decompression, whereas facial sensory changes is very less for the microvascular decompression, and it's very high for the internal neurolysis. And corneal hypoesthesia, hearing loss, motor weakness, cranial nerve palsy, meningitis, CSF leak, anesthesia dolorosa as well as mortality was very less for the stereotactic radiosurgery group. So final recommendation by the EAN guideline is based on a very low quality of evidence. The medical management is recommended before offering surgery for trigeminal neuralgia, and patients should be offered surgery if pain is not sufficiently controlled medically or if medical treatment is poorly tolerated. And so which surgery to be recommended first? So microvascular decompression is preferred, and for classical trigeminal neuralgia, but no recommendation can be given for choice between any neuroablative procedures. So the Cleveland group, so based on the when the timing of surgery, so when or which surgical operation should be offered, so that is not clear. So now, should the patients with secondary trigeminal neuralgia be offered the same pharmacological as well as surgical treatment of pain? So EAN's final recommendation is based on a very low quality of evidence, means medical treatment of patients with secondary trigeminal neuralgia should be similar to those with primary trigeminal neuralgia. Surgical intervention should consider either Caesarean ganglion procedure or microvascular decompression. So now coming to the prognosis, it is variable in trigeminal neural, in each patient. And so this study with 186 patients with trigeminal neuralgia, so they tried discontinuation of treatment after 2 years, but most of the patients continued with symptomatic management, and they couldn't taper the medicine even after 2 years. So now future perspective is third generation anti-seizure medications like eslicarbazepine as well as lacosamide are promising, and the drugs that inhibit CGRP have revolutionized migraine, and their applicability to trigeminal neuralgia is not established. So that is the area of that can be considered and for study. And other new agents of interest include lesmeditin, pimoside, tisanidin, as well as lamotrigine. And there are only case studies as well as few small clinical trials in literature. So robust research that is in support of this agent specifically. It is very rare and it can be considered in future. Thank you. Ma'am, in that they have told that in MS, this neurovascular compression was also in patients with MS, neurovascular compression was also there. And out of 10, 5 had very good response after microvascular treatment.
I think Lakshmi has covered everything extensively. I just want to stress upon 2-3 points. Summing up the treatment modalities, usually you need to consider for first line, as she told, carbamazepine or oxcarbazepine. And the second line of drugs usually preferred are the gabapentin, lamotrigine, and pregabalin. If you find a neurovascular conflict on MRI, like either atrophy or distortion or compression, usually by superior cerebral artery or ICA on the trigeminal nerve, then you need to consider microvascular decompression early rather than the ablative procedures. This is the guideline they have given for the surgical management. But if in MRI you are not finding any evidence for neurovascular conflict, that if it is not a classical trigeminal neuralgia, then after all these drugs, you can try the other add-on drugs which she mentioned, baclofen, Botox, and everything. With that also, if there is no improvement, then you can consider for radiofrequency thermal coagulation or ablative procedures, glycerol lysolysis, what else she has told. So this is about the management summary. And then the most important thing is when the mimics of the trigeminal neuria which have to be ruled out, because management completely differs in between the mimics and the classical trigeminal neuralgia management. What are the things which are atypical for the pain of trigeminal neuralgia? That is what you need to focus on. The thing is, V2, V3 distribution, you know that occurring in paroxysmals, you know that it is trigeminal neuralgia. If there is predominant V1 distribution, if instead of paroxysms, you find that a persistent pain is there. If there are other add-on symptoms like numbness and numbness, if you are finding it predominantly, then you need to consider a neuropathic pain. And the other most important thing is absence of sensory triggers. If there are no sensory triggers, then it is highly unlikely that it is trigeminal neuralgia, and you need to consider other mimics. And among the mimics, top to bottom, you need to consider mainly the dental ones and carotid dissection, which is very important and not to be missed, and sometimes can mimic a trigeminal neuralgic pain. In that, there will be some worsening with the neck movement, and there is thunderclap, headache character. The pain character would be different. And then very rarely, certain brainstem lesions can also mimic trigeminal neuralgia, and the brainstem stroke also can mimic the trigeminal neuralgia. Apart from that, you need to consider neuropathies. If there is an underlying numbness and if the pain is persistent, main neuropathies which are to be ruled out are the greater auricular nerve neuropathy and the lesser occipital nerve. For that, you need to question the patient if there are any prior procedures, manipulations, surgical procedures that are done, if there is any past history of trauma, and if there are any parotid surgery it has been done recently. These are some of the other things which you need to focus. Otherwise, the management is as she has guided.
We have concluded this.
V2, V3.
V2, V3. We are concluding the session. Thank you.